Welcome to this explainer. Today, we're going to completely demystify hemodialysis. It's one of those medical procedures that just sounds incredibly intimidating, right? But honestly, we're going to break the whole thing down. We'll explore the underlying biological problem, the absolute mechanical marvel that solves it, and the profound human adaptation it takes to live with it. Let's get right into it.
Okay, here is our roadmap for today. We are going to look at when kidneys stop working, 2, the artificial kidney machine, 3, access the blood lifeline, 4, side effects and complications, and 5, diet, lifestyle, and thriving. We'll follow this journey step by step. Section 1, when kidneys stop working. To really understand the treatment, we first have to understand the biological villain of our story, which is, well, the failing kidney itself. So what actually happens when your body's built-in hyper-efficient filtration plant just breaks down? Your kidneys are absolutely crucial for whole body homeostasis. They regulate acid-base balance, electrolytes, blood pressure, the whole shebang. So when they fail, it's not just some localized issue, it's a systemic crisis. Waste products and extra water literally just begin to fill up the body.
It's honestly staggering to think about the sheer volume of work that healthy kidneys do without us even noticing. The kidneys are sophisticated reprocessing machines. Kidneys process about 200 quarts of blood to sift out about 2 quarts of waste products and extra water per day. 200 quarts every single day. That is a massive operational burden. So when that natural system fails, all those toxins and excess fluids just have nowhere to go, placing this immediate life-threatening burden on the body.
To figure out what's going on, doctors rely on a crucial metric, the glomerular filtration rate, or GFR. Basically, this is the performance score of your internal filtration plant. They estimate this by looking at creatinine, which is just a normal muscle waste product floating around in your blood. If your kidneys start slowing down, that creatinine builds up and your GFR number drops. And that GFR metric helps categorize chronic kidney disease into 5 distinct stages. It's a progressive decline, really. Stage 1 is a normal GFR of 90 or above. Stage 2 dips to 60 to 89. Stage 3 is 30 to 59. Stage 4 drops to 15 to 29. And then, Stage 5. This is kidney failure, where the GFR drops below 15. At this critical threshold, life-saving mechanical intervention becomes absolutely necessary. But what actually triggers this decline in the first place? Looking at the data, it's a bit sobering to realize that everyday conditions are the main culprits here. Based on major study data, hypertension accounts for 40% of end-stage renal disease, followed by chronic glomerulonephritis at 20.5%, diabetic nephropathy at 19.8%, and other causes making up the rest. The tiny, delicate blood vessels in the kidneys simply cannot withstand long-term exposure to high pressure or high blood sugar. Section 2, the artificial kidney machine. Once the biological organs fail, well, we have to turn to an ingenious piece of modern engineering to step in and save the day. And this brings us to the mechanical hero of our explainer, the hemodialysis machine. It effectively acts as an external, artificial kidney. It takes over all that heavy lifting for the body by routing the patient's blood through an extracorporeal circuit. That's just a fancy way of saying the blood goes outside the body to get cleaned before being safely returned. If we break the hemodialysis cycle down into 4 continuous steps, you really get a feel for how it works. Step 1, blood is drawn out via an access point. Step 2, blood is pumped through the dialyzer. Step 3, dialysate fluid draws out impurities via diffusion. And Step 4, cleaned blood is returned to the body. It's a continuous, closed loop that systematically replicates the natural filtration process of a healthy human body. To actually pull this off, the machine relies on 2 main operational forces. On one side, you have the mechanical blood pump, literally driving your circulation while it's outside your body. On the other side, you have the dialysate concentrate and water supply. Now, dialysate isn't just water. It's a highly formulated, specialized chemical solution designed to magnetically pull out impurities, like urea and excess potassium, while leaving all your essential minerals totally alone. If we zoom all the way into the microscopic level inside that filter, we find the semipermeable membrane. Think of this as the ultimate biological bouncer. On one side of this wall is your blood, on the other is the dialysate flowing in the opposite direction. The microscopic pores in this membrane allow excess water and tiny waste molecules to cross over and get washed away while keeping your larger, vital blood cells and proteins safely intact on your side of the wall. It's brilliant. Section 3, access, the blood lifeline. But here's the catch. To perform this mechanical miracle, doctors first need a reliable, super robust physical connection to your circulatory system.
You see, you can't just use a normal IV line for this kind of blood volume. There are two main surgical options. First, the arteriovenous fistula, which is considered the gold standard, created by directly joining a patient's own artery and vein. Second is the arteriovenous graft, which joins them using a synthetic, soft tube. The fistula is definitely the superior choice here. Because it uses your own natural vascular tissue, it results in way fewer infections and lasts a lot longer than a synthetic graft.
Now, you might be wondering, why merge an artery and a vein in the first place? Well, arteries have high pressure, while veins are collapsed with low pressure. If you hooked up a normal vein to the dialysis machine, it would just collapse under the intense suction. By combining them, surgeons harness that high arterial pressure to create a super vessel, one strong enough to handle the machine's intense 200 to 400 milliliter per minute flow rate without rupturing. Because this relies on a natural biological adjustment, getting this access ready requires a pretty strict timeline. A vascular surgeon evaluation happens about 6 months prior. Surgical placement is done several months prior, and then it takes 4 to 8 weeks for the vessel caliber to mature and be ready for use. You literally need weeks for the human body to naturally expand and strengthen that new vessel. So proactive planning? Absolutely a matter of life and death.
Section 4, Side Effects and Complications. Now, while this is incredibly life-saving, mimicking a human organ mechanically is a very aggressive process, and it does come with some intense physical side effects. Because we're rapidly removing fluid and altering blood chemistry in just a 3 or 4 hour window, the body kind of goes into shock. Hemodialysis risks include intradialytic drops in blood pressure, muscle cramps from rapid dehydration, heavy post-treatment fatigue that patients often call a dialysis hangover, and severe infection risks like Hep B or Hep C at the access site. It is a really tough process to go through. And because the machine is so incredibly powerful, it can sometimes outpace the brain's ability to adapt. This leads to something called dialysis disequilibrium syndrome, or DDS. It's a rare but severe complication involving brain edema, and it's caused by the overly rapid removal of urea from the bloodstream during treatment. Basically, cleaning the blood too fast causes fluid to rush into the brain. It just goes to show why doctors have to constantly monitor and carefully prescribe the exact speed and dose of the dialysis.
Section 5, Diet, Lifestyle, and Thriving. Finally, let's look at how the patient regains agency. Beyond the clinic walls, how do they adapt their everyday lives to actually thrive alongside this new mechanical kidney? Between those machine sessions, the patient's discipline literally becomes their own medicine. Dietary modifications are huge. They have strict fluid intake limits, must keep sodium very low, and have to avoid high potassium foods like dry fish, spinach, and cold drinks. Instead, they opt for safer foods like cereals, paneer, boiled vegetables, and papaya. Because the machine isn't running 24/7, they have to meticulously manage what goes in to prevent toxic buildup.
When you put all of this together, it requires an absolutely mind-boggling commitment. 5,000, that is the total volume in cubic centimeters of a patient's entire blood supply that completely circulates through the dialyzer every 15 minutes during a standard 3 to 4 hour session. 5 liters. Surviving this means dedicating yourself to a procedure where your entire body's blood volume is pulled out, scrubbed clean, and put back in multiple times an hour, multiple days a week. Wow.
Knowing that patients can live and actively thrive for many years on dialysis, we have to look to the future. As technology advances towards daily and nocturnal home hemodialysis, how will our perception and management of chronic, machine-dependent illnesses continue to evolve? How will the everyday experience change when the hospital machine becomes a quiet fixture beside the bed? It's an absolutely fascinating frontier for medicine and for human adaptability alike, something to really think about.